Good afternoon, everyone, and thanks for joining us. I'm Emily Clevenger, Director of Marketing at Employers Health. Before we get started, I have a few items to cover. Currently, all attendees are in listen-only mode. Please use the Q&A function on the left-hand side of your console to submit questions. We will address them at the end of the presentation. A copy of the presentation is available for download and can be found by clicking the paperclip at the bottom of your screen. You can watch for the recording to arrive tomorrow via email. Upon exiting the webinar, you will receive a survey to provide feedback. We appreciate all attendee feedback as it helps us shape our future programs. Today's webinar is titled Managing Diabetes Risks and Costs in Your Health Plan, Tangible Ways to Lower Costs While Also Improving Care. We want to thank the Diabetes Leadership Council for their sponsorship and for their joint leadership program with the Juvenile Diabetes Research Foundation. Joining us today is George Huntley. George is the founding member of the Diabetes Leadership Council and currently serves as CEO of both the Diabetes Leadership Council and its affiliate, the Diabetes Patient Advocacy Coalition. Also joining us is Aaron Turner Pfeiffer, the Director of Health Policy at the Juvenile Diabetes Research Foundation. And with that, I'll turn it over to George and Aaron.
Thank you, Emily. Good afternoon, everyone. I think it's officially afternoon on the East Coast. Not sure where everyone else is sitting, but you may be West Coasters and still be good morning. So thank you for spending some time today to talk about diabetes and risk management in the healthcare plan. My name is George Huntley. I'm the CEO of the Diabetes Leadership Council and also a patient living with type 1 diabetes for 40 years. Happy to be here. And I'm going to turn it over to Aaron for a second, then I'll go into the agenda. So Aaron, please say hi, and it's a pleasure collaborating with you, my friend.
Yes, well, hello, everyone, and George, so excited to be with you and join DLC on this important effort. And again, JDRF is focused on finding a cure for type 1 diabetes and improving the lives of those living with type 1 today. And so excited to be here representing the type 1 community, but providing education about kind of the broader diabetes space.
Super. And the Diabetes Leadership Council is a 501c3 nonprofit policy advocacy organization. Everybody on our board is a past leader of a national diabetes organization. So we're delighted to work with employers, work with and partner with JDRF and getting the messaging out there as far as what does a patient with diabetes need. In my other day job, I'm the chief financial officer of a professional services firm based out of Indianapolis, Indiana. In that role, I have been the plan administrator of a self-insured health plan for over 25 years. So I know what the employers are dealing with out there because I deal with it myself. Today, we're going to hopefully quickly in the next hour go through a cover of what the current state of diabetes care and coverage. What is diabetes? So everybody has an understanding of the problem that we're dealing with. We're going to cover the marketplace dynamics that influence this care and the costs that are driving it, because a lot of us are here because it's expensive. And then we're going to have some plan design discussion and bring in our third-party administrator to talk about how to design some plan design specific issues and opportunities to manage diabetes-related risks and costs. So it should be a full hour. If you have questions, please enter those into the Q&A chat down there that you see there, Q&A box. So please do that while we're going, and we'll answer as many as we can. And if not, we'll try to follow up with you later. So without further ado, I'm going to let Aaron take the first piece of this, and we'll go from there. Good. Thanks very much.
All right, thanks, George. And I recently learned as of about 10 or 15 minutes ago that my camera will follow me if I move. So I'm going to try and stay in my box, but I apologize. I do get excited talking about this, and so apologies if my camera's moving around a bit. But no, I just want to provide some high-level overview of the diabetes space. Our work here at JDRF is really raising awareness and advocating for folks living with diabetes. Over my shoulder, you can see, I think their heads are cut off at the top of the picture here, but from a recent Children's Congress, which is an event that we organize and host, we bring kids with type 1 diabetes and their families to Washington, D.C. for a few days, and they meet with their members of Congress. And this is, I believe, some folks with Senator Mitch McConnell over my shoulder. And just to highlight kind of what life is like living with diabetes. what goes into a day in care. And so excited to bring you all this perspective here today as well. As many of you probably know, diabetes is an epidemic. 1 in 8 adults, 37 million Americans living with diabetes today. Nearly 100 million folks, 96 million Americans with pre-diabetes, so those at risk of developing type 2 diabetes, which is, so there are two types of diabetes as shown here. Most folks have type 2, which means that they're insulin deficient or resistant. 5 to 10% of the population living with type 1, which is an autoimmune disease, which simply put means that their body doesn't produce insulin. So folks with type 1 require insulin to live, and a proportion of folks with type 2 also require insulin. So diabetes is chronic and progressive. Right now there's no cure for diabetes per se. We do have the first ever disease-modifying therapy that delays the onset of type 1 diabetes approved and available. We recently got the FDA approval for not we, JDRF, but the community has the first ever cell therapy for type 1 diabetes that will hopefully be launching in the near future. But that shows promise to prevent or delay some of the complications associated with living with type 1 diabetes. So amazing work being done in the research space and new therapies coming to market that can help prevent or delay the onset in type 1. But by and large, most folks are not going to have access to a cure that prevents or delays diabetes. But the good news is that diabetes, if appropriately managed, you can avoid many of the costly complications that are associated with poor glycemic control and with someone living with diabetes. So I just want to quickly highlight these. Approximately 1 in 3 folks aged 40 years or older have diabetic retinopathy. Folks with diabetes are 2 to 4 times more likely to die of heart disease. Almost half of new cases of kidney failure are folks with diabetes, and 60% of non-traumatic amputations are in folks with diabetes. And so these are not only just costly events for your plan, but these are real life-changing issues for someone living with diabetes. I don't want to spend too much time here, as I think most folks are probably aware diabetes is a major driver of costs in a plan. Insurers have reported spending nearly 3 times more per person with complications than someone without complications. And really what we want to underscore here is that we're spending a lot of money on complications and less on prevention. And so, I think not only does it improve the lives of those living with diabetes, if we can avoid complications, investment up front goes a long way in saving costs down the road. I want to spend a little bit of time here and really touch on the disparities that exist for those living with diabetes. So if you're not white, basically, you are at increased risk of diagnosis of diabetes. You can see here the scale increasing from non-Hispanic white at 7% all the way up to Native American, Alaskan Natives at nearly 15%. And so while the incidence and prevalence rates are increasing in non-white community, we see disparities in outcomes and access for those folks. And so people of color with diabetes are less likely to have access to a prescribed CGM. We're going to talk about that in a little bit more detail. Less likely to be prescribed an insulin pump. I want to highlight here that both the CGM and the insulin pump are the standard of care, but folks of color are less likely to have access to those. They're less likely to receive the education required to manage those types of technologies. And they're less likely to be prescribed newer types of insulin and glucagon medications. So they're also more likely to develop complications, so less access to some key innovative technology that's the standard of care, more likely to develop complications, more likely to be hospitalized with severe high or low blood sugar levels. And what we've seen this play out through the COVID-19 pandemic, these folks were more likely to be hospitalized or die due to complications associated with COVID and their diabetes. So we've got room for improvement. 16 million ER visits per year for the folks living with diabetes. You'll remember that 37 million Americans, I believe, have diabetes, so roughly half the number of ER visits here. And of those 16 million, roughly half are resulting in inpatient hospital stays. We don't have to tell all of you, some of the most expensive line items in any plan are going to be those emergency room visits and certainly those inpatient hospital stays. We're also not achieving some of the key metrics that we look for and good glycemic control and good management of someone's diabetes. So roughly 50% of folks are each reaching their A1C goals. Less than 20% are meeting A1C, blood pressure, cholesterol, and non-smoking goals. Those all go hand in hand with complications. And roughly 90% of folks with diabetes are overweight or obese. So, we got a lot of room for improvement here within the system. And, certainly improving on these improves the lives of those living with diabetes, but also points us in the right direction to save money for plans. And I think one of the things we really want to underscore here as you're thinking about your benefit design is diabetes is a self-managed condition. So for those who are Rent fans, I'm not going to sing it, but 525,600 minutes in a year. Of that time, roughly 2 hours, maybe less, are spent with a healthcare provider. And so, folks with diabetes are really doing this themselves with the support of their provider. And someone with type 1 is making 180 additional health-related decisions every day. And one thing to underscore is if you have a kid with diabetes, it's not just the kid, right? Their parents are actively engaged every day. So you might have employees who are constantly thinking about checking their kids' glycemic levels. And so those are decisions that are weighing on them as well. And so the more that can be done in benefit design to make it easier to manage diabetes, the better quality of life, the more money we're going to save, but also I think more productive employees we're going to have. I know that was quick, so if there are any questions, please do put them in the chat. We've got two great panelists here. I want to bring on Dr. John Anderson out of the First Clinic in Nashville, and Donna Ryan, formerly with Ascension Health, fresh into retirement here, coming off the beach and joining us. So thank you, John, and thank you, Donna, for joining us. Yeah, there's Donna. Hello. And I'm just going to jump right into it. John, I want to get you started here with the first question. I think it's always good to just have a good kind of level set on what's happening in someone's body who has diabetes.
It's a great question, and we could get really complex, but let's just be straightforward and simple about it. Diabetes, whether it's type 1 or type 2, is a disease of energy metabolism. The blood sugar, or glucose, is used by the body, ingested, and used for fuel in all of the cells: brain, muscle, liver, tissue. In fact, kidneys and brain use glucose exclusively. So in type 1 diabetes, you have people who have a deficient autoimmune system, and that's the 5 to 10% you referred to, whose bodies attack the beta cells that produce insulin. Insulin is the hormone that moves glucose out of the bloodstream and into all those cells and organs for fuel. If you can't do that and glucose is high in the bloodstream, glucose is a toxin. It's a toxin to the small blood vessels of the eyes, of the kidneys, and the feet. And of course, along with smoking, hypertension, other things, you can have large vessel disease, stroke, and heart attack. In type 2 patients, it tends to be a problem of insulin resistance. They produce insulin, but they don't use the insulin very well. So anything that improves insulin resistance, and that includes weight reduction, improves the ability for insulin to take glucose, move it out of the bloodstream, and then move it into the cells for fuel. And what we also know about type 2 diabetes, Aaron, is that over time, many of these patients, as you said, it's a progressive disease. Many of these patients, even with type 2 diabetes, are at some point in time going to need insulin in addition to all the other therapies we have for people with type 2 diabetes.
No, I think, Dr. Anderson, I think that's so helpful. And I want to key in on a word you mentioned around weight and what the impact that has. I think we had a stat in here showing about 90% of folks are considered obese. I can't read really a headline around healthcare costs right now without hearing about some of the new drugs impacting weight loss. I'm just curious if you can reflect a little more detail on what weight has to do with kind of managing diabetes.
Right. Well, Aaron, you referred earlier about the ethnicities, people of color being at much higher risk of getting this than a Caucasian population. So that's one of the things driving diabetes. One of the other things driving diabetes is we're living a lot longer, and the longer and more you age, the more likely you are to get type 2 diabetes. But certainly overweight and obesity epidemic in the United States is fueling the increase in type 2 diabetes, up to that 4 million or so patients that may have type 2 diabetes. I live in the Southeast, which we call the, diabetes belt because of obesity, ethnicity, and that type of thing. And so anything that helps to lower weight, that helps to treat overweight and obesity, improves insulin resistance. The cells start to recognize insulin better. Glucose moves out of the bloodstream. So one of the key components from the American Diabetes Association, the European Association for the Study of Diabetes, is we should be picking therapies that not only lower glucose, but also address that overweight and obesity epidemic. And just to wrap it up, because you mentioned it, in the last year and a half or 2 years, we've had access to groundbreaking therapies, both oral and injectables, that not only lower glucose, not only some of them reduce heart attack and stroke, but also address that overweight and obesity epidemic. And some of these are injections. Many of these are very expensive. But you talked about how much money we spend on the back end, when spending the right amount of money on the front end could markedly alter the course of the patients with type 2 diabetes and ultimately result in cost savings.
No, and thank you, Dr. Anderson. I think that's so thorough and so important. I think Novo, maybe last night or this morning, just published some data on Wegovy showing, I think, great cardiovascular risk avoidance in there. So I think very timely here. I want to pull Donna in here, because I think one of the things that we talk about, and I think it cues up nicely because so many of us can relate to trying to lose weight and managing kind of that whole process, how difficult that can be. We know diabetes is difficult to manage as well. So I'm, Donna, just curious, in your experience working with folks with diabetes, reflecting on how, their journey, how difficult it is, and the support that's required from someone on a day-to-day basis.
The lifestyle behavior changes that are successful require increased exercise, decreased calories, and a combination. But across the lifespan, from teenagers to adults, there's a lot of factors that go into that. And as you can see on the screen, it takes commitment, but it takes education, self-management education, and behavior education. And we find that 50% of the people that have that kind of support, diabetes and weight management education, are successful in losing a percentage of their weight and keeping it off. And when you combine it with the medications that Dr. Anderson's talking about, then you increase their chance of taking it off and keeping it off. And it really is the sustainability of the weight loss that we're going with. And then you have the improved cardio and glycemic outcomes from that. People need help with this. And so health plans that can support that through lifestyle behavior modification, counseling, and medications. Really important issue.
And Aaron, let me weigh in real quickly, just on piggyback on what Donna said. It's so important these patients have education, but it's also important for our listeners to understand that obesity truly is a disease. There are all kinds of hormones in play here where the body defends its set point. If you lose 5% of your body weight, you have hormonal and central nervous system factors kicking in that increase appetite, trying to keep the body at that set point. So I think it's important to understand that obesity is a disease just like type 2 diabetes is a disease.
No, I think those are great points. And one of the I think great places that we're in right now in terms of advancements, both on weight management and how that impacts diabetes care, but also we got some amazing device technology that's now available. And we had talked previously about access to things like continuous glucose monitors, insulin pumps, how important those are for managing sugar and glucose levels. And so, Don, I'm curious if you can just kind of walk us through some of those devices, their impact, what they've meant for patients to get access to those.
Absolutely. Next slide, or I'm a slide behind. There you go.
Yeah, we go.
Okay. So absolutely, we have technology now that is so impactful and so helpful in people with diabetes to manage their blood sugars. The continuous glucose monitors that you've all probably seen in the media help keep your blood glucoses in range, and that's what we're looking at here on this dashboard. When blood glucose is close to normal, then we don't have the side effects and the complications as much as when they are roller coastering up and down. So that technology, continuous glucose monitors, is a game changer. It gives biofeedback. People see their blood sugars either on the device that they're wearing or on their phone, and what happens to their blood sugars during exercise, after they eat. And we see a very quick behavior change because they can see that impact. It's changed from having 2 to 5 blood sugar sticks on your fingers a day to having 288 readings per day with arrows of up and down on the glucose, on your glucoses. It's made a huge difference across all types of diabetes in all ages. So the numbers don't lie, and patients really respond well to that. We also have insulin pumps, and insulin pumps are a technology that are also life-changing for people with diabetes on insulin. There are several different models out there, and not one model is right for everybody. It's important that patients have access to the choice, along with their healthcare provider, on which insulin pump or insulin administration device that they have. These devices provide insulin drip, drip, drip all day long, and they can be set so that they provide more insulin during the times of the day that their blood sugars are higher, or that they need more insulin, and be modified for eating meals and exercise. It has been a game changer. And when you take that continuous glucose monitor, which we have now, and it communicates with the insulin pump, what you have is a wonderful dual technology that reads their blood sugars, gives them insulin with their goals of where their range and glucoses are. And we're seeing such great results from that. We have less low blood sugars or hypoglycemia, less high blood sugars, and less complications, which take us right back to lower cost and less acute care and emergency care utilization.
No, and Donna, I think it's so important to walk through, and you mentioned that there are many options now available, which is so important. So our last question here as we wrap up, I want to, Donna, get your feedback, and Dr. Anderson, your feedback as well. We talk about how important it is for choice, right? There are many options that are available. It's important that folks have access, because certain alarms will work for some people, and some folks don't need those alarms. And while it might seem insignificant, especially if we're thinking about, we often think about kids with type 1, getting a teenager to wear a pump or a CGM, something off their body where they might be self-conscious about. If you can find one that your kid is willing to wear, having access to that, it makes a world of difference. So I'm just curious if you all can reflect, I think for the audience here, what those conversations are like, how important it is to have choice in a wide range of these devices.
Well, I can start. And some of these devices are connected to the body with a tube. So you have your device and you have a tube that goes to the body. For kids and many people that don't want to be connected via a tube, they'd rather have just have the patch on their body and not the tube. It's a game changer. And with teenagers, that's really important. Offering them that, and then with children also. And then some people like to have the different designs that have the tube, and they also have different interfaces and what they look like and how they read to how the screen reads. So it's highly individualized, and it can be the difference in someone wanting to use a pump and not using a pump. If you can offer them something that fits their lifestyle, they're more apt to adopt it.
Yeah, and I would just add briefly, because I know we're running out of time on our segment here, Erin, but I have patients who crawl under houses for a living, right? Plumbers, HVAC employees. Having a loose tube is going to invariably pull out. Having a patch pump is incredibly important for them, because it's not just a preference. They literally can't use a pump that has a lot of tubing, or they have tried and failed. So again, having that choice, the availability for options, is key to an employer's health plan.
No, I think that's well said, and I want to let you release both of you all. We'll get to our poll here, but really want to thank both of you for bringing your expertise here today to the panel. And we have a poll question here, our first poll question of the day for the audience. I'm going to read it. In a recent study of 571 people with type 2 diabetes, what was the financial impact of using a continuous glucose monitor? A, net cost of $424 per month. B, a net cost of $53 per month. C, a net savings of $53 per month. Or D, a net savings of $424 per month. We'll give a few seconds here. Let folks have a chance to respond. I think that, and as we're waiting for responses here to come in, just to underscore kind of that last point around choice, it is one of the things that feedback we get from the community is it's really hard to find a management plan that works. And once you've found something that works, folks really don't want to have to, it's hard to adapt out of that. And so having a benefit plan that supports kind of that model and folks' choice working with their physician and care team are so important and impactful. And that's honestly where we see the greatest improvements in glycemic control and better health outcomes over time. So we got a good number of responses here. I'm going to go ahead and advance our poll. And a pretty good split of folks here between the 4 different options. And so for those who chose our 31%, $424 a month in net savings. These cost reductions were driven by reduced inpatient hospital costs. And again, we showed at the beginning that 8 million inpatient stays, 16 million ER visits for folks with diabetes. So there's real opportunity if we're designing benefit plans that work for people with diabetes, real opportunities at cost savings. And again, not just cost savings, but better lives and outcomes for those living with diabetes who are your employees and covered on your benefit plan. So with that, I want to thank you all for kind of this background and overview. Pull George back in here.
Hey, Aaron.
Hi. I know, George, you're going to walk through kind of the meat and potatoes of how the math here works.
Looking forward to it. Aaron, thank you so much for leading that panel. And thanks to John and Donna for sharing your expertise and insights today. Much appreciated. So I'll move us into, what's driving the costs when we think about the marketplace of diabetes and just healthcare as a whole. And let's start with drug pricing. Insulin is probably the poster child drug that everybody is talking about, because as a patient with type 1, if I don't have insulin, I'm not around. And the price of insulin over the past decade, the list price that you can see there has gone up 143%. It's gone through the roof. Yet the net price has been cut more than in half. So that delta that you see, that gap in between, is the growing rebates that have been included in these in insulin specifically, but they're included in all branded drugs. So right now, in the case of insulin, it can be over 70% of the list price. In fact, some cases, 80% of the list price is the rebate that's going back to the PBM. I'm going to talk about that, where that money flows in the next slide. But if your employees are paying list price, then they're literally paying double or triple what your plan is paying for that same drug. And again, the average is 48%. So if you just look at the average, if your people are paying list, they're paying double what you are paying for that same drug while they're in their deductible period. So let's talk about why that is and how the system is currently working. What's happening here is the consumer, your employee, they're paying a premium through payroll, typically, to be part of your health plan, to get access to the plan itself and the doctors and the drugs and all of those things. And so they're paying that sack of cash on the left over to you, to the insurance plan. But they're in the pharmacy in January or February during the deductible period, and they need to buy a vial of insulin. Now, by the way, they need about 3, or in some cases 4 or 5, depending upon what their level of insulin resistance might be, but many patients need 3 or 4 or more vials in a given month. So they're paying down to the pharmacist about $300 for a single vial of insulin if they're exposed to list price. So they've paid $300. Again, by the way, they need 3. And that $300, pharmacy's keeping maybe 25 bucks of it, 275 of it's going down to that drug company. The drug company is keeping about 50 bucks of that, and about $225 is moving over to the pharmacy benefit manager. Now, those numbers are general, they're relative. That's not in any given transaction. There's not a lot of transparency, but the generalities of and the proportionalities of that description are in fact accurate. So roughly 225 of that 275 has now gone over to the pharmacy benefit manager. And why did that happen? Well, the pharmacy benefit manager has taken that money in order to provide the manufacturer with access to the plan formulary. So that pharmacy benefit manager are Express Scripts, CVS Caremark, and Optum Rx. I'm going to go forward and I'm going to toggle back and forth here. These PBMs, these Optum Rx is the middle, the second row here. Optum Rx, CVS Caremark, Express Scripts, those three have 80 to 85% of the U.S. drug market. So they have a lot of power. And by the way, they're owned by insurance companies. United Healthcare owns Optum Rx, who owns the specialty pharmacy, who owns the care services. Aetna and CVS are one corporate family. Cigna and Express Scripts are one corporate family. And as a result of this, they're driving you to their own pharmacies and their own specialty pharmacies, and those rebates. I'm going to go back to this slide. Those rebates are providing access to the overall health plan and to the patients. It's big money, and we know here that rebate negotiation works. They're dropping the net cost of the drugs. They're dropping the net cost of the drugs for the insurance plan, but not for the patient. And unfortunately, the cost of the patient has gone through the roof. So I hope you're not getting dizzy on here, but this is all interrelated. Now, the pharmacy benefit manager is keeping a piece of those rebates and sending the balance up to the insurance plan or the self-insured employer, like my company. We're self-insured, so that's coming up to you. And the self-insured employer is taking that rebate, that piece of that, and you're getting probably 90% of that rebate. From what we know from the state of Texas is the pharmacy benefit manager is keeping around 10 or 12%. Now, any given contract is going to have a different result, but in general, these are general numbers. So most of the rebates going back up to the insurance plan or the employer, and the employer or the insurance company is keeping that as a big pool to help reduce that sack of cash called the premium. But the problem with that is we now have the sick subsidizing the healthy, and that's not how insurance is supposed to work. Insurance should be the many help underwrite the costs of the unfortunate few. And what we have here is the sick, with people with diabetes or any chronic disease, buying a drug, subsidizing the people who don't buy the drugs. During the deductible period, we should be passing that rebate through to the patient to keep the overall cost for that patient down and make them more likely to be adherent to their drugs, to their drug therapy. So we're going to talk a little bit more about that, but hopefully you see the funds flow here, and the money's not going back to that consumer at this point in time. So I've covered this. I'm going to jump back to here to remind us this rebate is on every branded drug out there. So this is not a generic drug. This is not necessarily a specialty drug, but a branded drug. They all have rebates, and it doesn't matter what the disease state is. They all have rebates, and the average one is 48%. So we're going to talk about, what if we were to pass these through at point of sale, what would it actually cost? Because we all care about cost. And the good news is it's not going to cost you much at all. If anything, I'm going to suggest that it's actually going to save you money. So we have an actuarial study that looks at it that says just passing those rebates through to the patient would have an overall less than 1%, 0.4% to 0.6% of the overall plan cost would increase. Now, that does not look at having healthier patients on your plan, because what you're doing if you're inflating the cost of that drug, and you're inflating it by double. You're training people to ration their drugs to be non-adherent to therapy, and that's not in your best interest. It's certainly not in the patient's best interest, but it's really not in the plan's best interest because drugs are there to save major medical costs. As we were talking about heart attack, stroke, ER visits, take the medication, avoid the ER, avoid the inpatient hospital stays. We're really not being we're not being strategic in the plan design when we're overcharging patients, and we're not thinking about it. The other thing to think about here is drugs are about 20%, 15%, 10 in that regard of the overall health plan cost. So it's the tail wagging the dog. And the last point I'll make here is a patient with a chronic disease like diabetes, and in many of your cases here, people who are using these drug therapies, they're going to meet their deductible 100% of the time. It's a question of when, not if. And if you overcharge them for the drug, one of two things is going to happen. One, they're going to ration their drugs and you're going to have a poor health outcome because they can't afford the cash flow. And two, you're simply going to pay another claim early. You're going to pay a doctor visit, a lab, something else early that you would not have otherwise paid because now they've met their deductible prematurely. Zero savings to the plan, total false economics, and you've increased the risk of your plan design as you've gone. And here's another illustration of very normal plan designs for the cost of, in this case, insulin. But you can have those on the left that first dollar preventive coverage, a low predictable copay, $0 to $25. You're going to have good adherence to therapy. In the case of insulin, if you're passing through the rebate, they're still paying $360. And this person is probably a type 2 needing a lot of insulin, but that's a lot of money that they're still paying even after you've passed through rebates. And if they're in full retail, that's got a comma in it. How many of your employees can afford a maintenance drug that they need to survive and afford a comma in there? Really look at this. We know that 69% of patients will abandon a prescription altogether if it's cost more than $250. So you're not getting the right health outcome. You've increased the risk of getting a much worse claim that you are going to have to pay for if you're not really looking at bypassing that deductible and getting those chronic disease patients into an affordable, predictable cost share as we go. So I'm going to switch us to a poll question here and ask the audience, does your organization offer at least one plan with full rebate pass-through to plan members? Again, this is just during the deductible period. So, during the deductible, are you passing rebates through? After the deductible, of course, you're getting the rebates because the participants are just paying their copay. But during that first quarter of the year, first 5, 6, however many months the person is in their deductible, are you passing it through to them? You can pass it through to them. All of the PBMs will do it, but you have to ask them to do it. You've got to tell them to do it. As a self-insured employer, they'll do whatever you tell them to do, pretty much. So I'm gonna move us along here, where I see a lot of people have answered. So I appreciate your playing along at home. Nobody is doing it. Nobody in this group is doing it. 77% are no, and a couple of you don't know, and I understand that. And I would look at this to say this is an easy thing to do that will statistically cost you virtually nothing, and will substantially improve the likelihood of your participants taking care of themselves, which is really what you want them to do. I'm going to talk a little bit about how these rebates drive some really perverse behaviors. So you look at the insulin market, and I'm using insulin as an example. This happens in other drugs. Let's just take Eli Lilly, the Humalog, which is the left-hand column are the 3 brand name drugs, if you will. Humalog, Novolog, Lantus. Humalog is insulin Lispro. On the far right-hand side of that row, you see insulin Lispro. That's made by Eli Lilly. So is Humalog. It's the same manufacturing plant, goes into the same glass vial, and they slap a different label on it to unbrand it so they can charge it and sell it for less money, because their contract with the pharmacy benefit manager says I cannot sell Humalog for less than this list price. Novolog, same story. In fact, Novo Nordisk, all three of these drugs on that column in that middle row, all three of those are the same drug, the same manufacturing plant, all Novo Nordisk, all going into the same vials, slapping a different label on it. Why did they do that? They did that because they're getting beat up so much that they are not allowed to sell that for a lower price, but they needed to go out of the way to find a way to do it. Semglee on that lower row is a biosimilar to Lantus. Insulin Glargine is a generic of Semglee. They went to launch Semglee as a generic itself, and they wanted to launch it less than $100. No formulary picked it up. So they literally the manufacturer had to come out with two versions of it so they could raise the price and get on the formulary. I will repeat that. They had to raise the price to get on your formularies. Your lower cost drugs are not on the formularies. It's the same drug. So the net cost is the same, folks. These are games that the PBM's playing, and it's hurting because now your generics and your biosimilars aren't always the ones that are on there. This is Medicare Part D data because it's public. I can get this data, but it's the same PBMs, the same folks that are driving your plans are driving these. In the first year of launch, only 1 in 4 generics are being covered. They're being blocked out. Less than half of them are on the generic tier of your formulary plan, meaning there is no incentive for your people to take the lower cost drug because the PBM honestly doesn't want your people to take the lower cost drug because they're taking a piece of that rebate. And that piece to them is quite significant to their bottom line. So you're not getting the low cost drugs, which means your people on your plan in January are forced to pay, in some cases, astronomical prices instead of having the option within your formulary of a more affordable range during their deductible period. Not good for them, not good for their therapy, frankly, not good for you. We've talked about obesity coverage. I'm not going to spend a lot of time on this, but you guys will pay we'll pay for gastric bypass. You'll pay to rip out their intestines, but you won't pay for the drugs that will prevent the need for that surgery. So I urge you to take a look at these new medications that are going online. In many cases, they're not covered. In many plans, they're not covered. You're following the federal laws. When they put Medicare Part D enacted that into law in 2006, they wrote into it that it could not be used for weight loss. There were no weight loss. There were no real effective weight loss drugs at the time. What was there was fen-phen, was effectively speed, and was killing people. So they wrote that into the law. Many commercial plans are following that, but there is likely a scenario where you could avoid gastric bypass. I would urge you to take these drugs are coming out. They're new, and they are super effective. And as a patient advocate, it's not the patient's fault. Let's help the patient. Investing in diabetes management pays off. Here's a study by Express Scripts in 2022, last summer, capping the cost for diabetes medications at $25 a month. And that's not just insulin, all diabetes medications, capped at $25 a month. Increased adherence to therapy. That shouldn't shock anybody, but we now have it in black and white, or purple anyway. And resulted in a 16.3% overall reduction in medical costs from diabetes. That's our goal. Our goal is to reduce the overall cost of diabetes. I'm not trying to reduce the cost of any one drug or any one therapy or one sensor. We're trying to stop the hospitalizations. We're trying to get to a overall lower cost so that the patient can be healthier. That's a huge savings that can be done from there. Look at your plan design and let's see what we can do about that. I'm going to push us to a poll question here and ask, does your health plan offer first dollar coverage pre-deductible for diabetes management. So this is where chronic disease management is bypassed the deductible, even in a high deductible health plan. Now, some might think you're not allowed to do that. You are, in fact, allowed to do that. The IRS clarified that pre-pandemic, 2019. They clarified that a health plan can take chronic disease management and bypass that deductible and that preventive drug list. We're all familiar with that. We can drive that for chronic disease management because you get better adherence to therapy, you get lower overall costs, and many forward-thinking employers were looking at that saying, this is in our best interest. Can we do this? You can do this, but not all of us are doing this. So this is just a challenge to you to take a look at it and to see where are we today. So yes, no, not sure. It's a challenging thing to go back and look at your plan every year and see where we are with it. I'll let a couple more people weigh in on this. I do appreciate your playing along at home with these poll questions. It's interesting to us as we go through this, and hopefully interesting to you to see how your peers are doing as well. So I'll push this forward, and this is an interesting split. So we've got 40% of the audience are treating first diabetes management as first dollar coverage. That's great. I applaud that. That's great, fantastic. Half of the audience is not. I would urge you guys to take a look at your plan design. You're going to save money in really the short and the long term. That's the beauty of diabetes management because the ROI on this comes very quickly. And 10% are not sure, and I get that. That's reasonable. So hopefully this will encourage you to go home and take a look at this. So thanks for that. I'm going to now invite my friend Rich Musti to join us here and unmute himself and turn on his camera. Rich Musti is the co-founder of Unified Group Services, located in Anderson, Indiana. Rich is a licensed insurance agent and a member of the Society of Professional Benefit Administrators and the National Association of Health Underwriters, which, is now, I need to update my script. I'm sorry. It's the National Association of Benefits and Insurance Professionals. They changed their name. And the Self-Insured Institute of America. UGS, Unified Group Services, is a full-service third-party administrator for self-funded group health plans dedicated to providing employers with innovative programs, services, and tools needed to effectively control employee health costs. In full disclosure to the audience, my company that I am the CFO of, called Theris Group, we have worked with Rich, and Rich and I have worked together for well over a decade at this point. It seems we're joined at the hip when we come to these things. So, Rich, I really appreciate you taking the time to share with us today. You start off, if you would, just describing a little bit about the type of self-insured employers you work with, to let the audience know who are you working with, and so they can hopefully see themselves in your scenario.
Sure. Thank you, George. Typically, we would consider it the middle market. It's not the rather large groups, but in that middle market, under 2,000 employees, but serve over 200 self-insured groups. We take this subject that we're all on right now very seriously, and take a very active role with our customers in managing the prescription piece. We find that to be many times low-hanging fruit and opportunity to really help our clients that's not working with the right people, and particularly probably the right pharmacy benefit manager to mitigate cost and give people the best chance of getting prescriptions at a cost-effective manner and being compliant.
Yeah, and I certainly appreciate that. And we've worked together for a number of years, and you've always had us passing rebates through at point of sale. And I've learned a lot in this process, and of course from doing these programs. How many of your clients are actually passing those rebates through, and what caused you to drive that practice for them?
Answer the first question, George. I would say it's in the neighborhood of 80 to 90%. many times we have the conversation with these prospective customers and customers that they weren't even aware of the potential of having rebates at point of sale. We've been doing it for about 20 years. We was able to partner with, there's some PBMs out there that are amicable and very good at doing that. And what drove us to that, George, was quite simply employers saying, what can I do to give my people the best chance at getting things at reduced cost and the most effective cost setting. And that it goes across the continuum, not just RX here, but from the medical perspective. So it's really trying to give patients the best chance at getting the necessary prescriptions at again, the lowest cost.
And when we go to the PBMs and say, hey, I want to pass these through, are they cooperative in this? What does it take to, what does it take? You need a big stick? What's it take to get them to do that?
It runs the gamut, George. Some, if you go to one end of the spectrum, say we flat can't do it, we'll give those to the employer. But then you go the other way, and there's some that we're fortunate we've been able to partner with to say, absolutely, that's part of our process. We'll deploy those at point of sale rather than wait to give the money back to the employer after 9 or 12 months. I mean, the employee saves immediately. And in our case, I'll just tell you how this works. We have to bill our customers every 2 weeks. Every 2 weeks, we bill them for the prescriptions that their people have purchased in the last 2 weeks, and we have to get the PBM money promptly. So every 2 weeks, we're billing them for all the prescription claims, and it's that much less because the rebates were deployed at point of sale. So they save immediately, at least 2 weeks later, and employees saved at point of sale 2 weeks prior to that purchase.
Yeah, it's important to get that cash flow. And as advocates and for the audience, is one of the things the Diabetes Leadership Council also gets involved in, and our affiliate organization, DPAC, we get involved in trying to pass state laws requiring these rebates to be shared with patients. I mean, we're paying a premium to get access to Sam's Club, and we're if you don't pass them through, you're charging them Tiffany's prices. So you're seeing some legislative movement towards this. And what I found in trying to educate state legislators and members of Congress on this, almost all, in fact, all of the top 3 PBMs say they'll do it. And in fact, their executives come out on record and say, we think it's a good idea to share these rebates with patients, but they're not actually doing it. And that really becomes the challenge. Where they say one thing, they agree, and we saw the Express Scripts study that says you cap the cost of diabetes drugs, you're going to save overall plan dollars, yet that's not what they're doing, because they're voting. They're saying one thing and they're voting with their pocketbooks, which is where the rebates are coming.
Absolutely, George. I mean, I know we were limited time here, but yeah, that answer, and for lack of a better word, is hokey in that you're pushing the balloon down on one side and pushing it up on the other, and they're not being fully transparent. Our pharmacy benefit arrangements are 100% audible, 100% transparent, and the PBM is only paid on the administrative fee basis on a prescription or a per employee basis, and they're not partaking in the rebate.
And that really is, one of the messages hopefully the audience is getting is the PBM is your vendor. And so as the customer, as the client of that vendor, you've got to drive the vendor to the most appropriate contractual terms for you and your participants as we go.
And we feel strongly, George, as being our job is not to just generate transactions. We take it very strongly to help manage costs. So we take it very serious as to bringing to the table a contract that is solid and is adhering to what was stated, and again, help these employers manage the cost. I mean, I'll just divert off just real quickly. One thing that we've done too, many customers, and this isn't picking on the big pharmacy chains, but the rebate is much higher when you narrow down your network and say, you can't go to CVS and Walgreens and narrow it down to, let's say, Walmart and Kroger and the mom and pops. And you didn't, yeah, your people maybe not have quite as much access, but I'll give an example. We see the rebate. I mean, Ozempic is a very popular drug right now, very well advertised and utilized. And we see the Ozempic rebate, instead of being $145 at point of sale, by limiting to lesser pharmacy, it goes to $345. That's real life numbers today that we're experiencing. So that person's cost, instead of being $800, is going to be $480 or whatever those numbers are exactly. But it's significant difference. We're not pushing or trying to get rebates, but by golly, like you're saying, if the plan has to cover and does cover name brand drugs, let's make sure those rebates are taken advantage of at point of sale.
Yeah, and get them to the people, but it also illustrates that what kind of volume you can drive. We do have some questions in here on the anti-obesity medication, so I want to talk a little bit about that. So first question from your standpoint, are you seeing your clients, your customers covering anti-obesity drugs, the Wegovys, and are you seeing them cover it just in type 2 diabetes or in obesity overall? Do you have a sense of that at this point? They're relatively new in the market, but do you have a sense of that right now?
No question. The majority are covering it for diabetes, but excluding it, for weight loss management. But that is really a daily topic, and I think we'll see that pendulum slide. But for now, we're seeing that being excluded at this point in time. I think until the clients are better educated. Yeah.
I think time, we need more data, we need more time in the market, but I think I'm seeing the same thing. So I appreciate you putting this in. There was another question in here. Somebody asked that do these weight loss drugs require them to stay on them forever? And the answer that I've got from we do a medical version of this, and the answer is yes. When the patient stops taking these anti-obesity medications, the weight does come back on, and these are best and more effective combined with diet and exercise as we go. But the current science says they have to stay on these, forever. So we've got to, and for those that are unaware, these drugs are hormone replacements. These drugs are replacing a hormone produced in the gut that tells the stomach when to empty and tells the brain that you're full. So in the case of obesity, that hormone's not working, so the signal's not getting to the brain, and it's not things aren't working the same way with the disease of obesity. So that's really what these drugs do. But as we know, with hormone replacement, you need the hormone, and if you stop taking the replacement, you go right back to where you were. So unfortunately, that's the reality. This is not the patient's fault. It is a disease, and there's something biologically not working. We are at the end of our hour, Rich, and I really appreciate your time so very much. There's a lot that I'd love to talk through here. I'm going to take us to a final, if I can, poll question to the audience that hopefully, if you are willing, if after you've seen this presentation, we've got you thinking about it. I would be curious if you are, after this kind of dialogue, would you be more willing to consider this of passing rebates through at point of sale? That would be, appreciate it if you play along at home. Some of you are hopefully still around and still be thinking about us here. I'm going to wait for a few more responses. I appreciate you paying attention. We're 1 minute after the hour here. I'm going to push that through. 84%, 15% already doing, so that's great. Thank you very much for that. And that's not proportional to the prior version because not everybody had a chance to weigh in on this. I really appreciate everybody's attendance today. I would urge you to go to our website, the diabetesleadership.org website, and we have some other handouts and things, information for employers on looking at copay assistance, looking at rapid approval, looking at telehealth and insurance literacy. All of these things will help your participants dealing with a chronic disease, maintain their disease, manage their disease, and lower your costs. I thank you so much for your time and sharing your hour with us today.
Thanks, George, and thanks to all of the panelists today. We hope you have a great, we hope you and your families are staying safe and have a great rest of the day. Thanks again for joining us, and thank you all for your time.
Thanks, everybody.